I just want to thank you all for joining this session as part of the webinar series. It's a joint effort between SPARCC and the Canadian Spondyloarthritis Association. And my name is Brenda Delodder, and I'm the executive director with the CSA, and I'm absolutely delighted to be the moderator here today. This is our first ever hybrid event, and so we think it's going to go smoothly, but if there are a few hiccups, please, if you're virtually, use the chat function and we'll get through that together. And we also have this being translated live for those who are joining us who wish to receive the information in French. And what I'd like to do is to ask everyone virtually to please let us know where you're coming from. We want to hear the names of those communities from which you live. And I also wanted to mention that we have 3 amazing experts here, as you've all have seen on the invitation. I hope that you can hear me okay. And we're thrilled to have these individuals joining us. This will also be recorded. I haven't heard it, but I'm sure the people virtually have heard a little message saying that this session is being recorded. But before we begin, I would like to acknowledge the Indigenous peoples of the lands that we are on today. While we meet today in a hybrid format, both in person and virtually, we do take a moment to acknowledge the importance of the land which we each call home. I reside in the region of Hamilton, Ontario. This event live is taking place at Toronto Western Hospital, and these are part of the treaty lands of the territory of the Mississaugas of the Credit. We recognize that those joining us are doing so from various treaty lands, and we are grateful to have the opportunity to work and live on this land, and by doing so, give our respect to its first inhabitants. This is a common slide that many see in our webinars, and just wanted to state that the information provided today is not designed or intended to constitute medical advice or to be used for diagnosis purposes. Due to unique individual needs and medical history, please consult with your own healthcare provider who will be able to determine the appropriateness of information for your specific needs.
Nous rappelons que nous offrons une traduction en français en direct pour la diffusion du forum des patients de ce soir. Pour accéder à la traduction française, veuillez suivre les instructions à l'écran ou dans le chat.
So I now have the distinct pleasure to introduce our expert guests here with us today. And as I do, thanks again for those who have submitted questions in advance. We will address those questions submitted first and live here today, and we'll try to get through all the questions that are submitted throughout this event virtually. And you can do that by using the chat feature. I'm just going to pause here for just a moment. I'll just introduce the 3 and then that sounds wonderful. Okay, super. So I would like to introduce you to Dr. Robert Inman. Some of you are very familiar with him. And Dr. Inman completed his undergraduate degree at Yale University and his medical degree at McMaster University. He did his training in internal medicine at the Vanderbilt University and his fellowship in rheumatology at the Hospital for Special Surgery in New York. He completed a research fellowship at the Hammersmith Hospital in London and then moved to the University of Toronto, and we are so fortunate for that, and where he was appointed professor in the departments of medicine and immunology. He is currently co-director of the Schroeder Arthritis Institute, co-director of the spondylitis program at Toronto Western Hospital, and deputy physician in chief for research at University Health Network. He is also an executive of the Spondyloarthritis Research Consortium of Canada. I'm going to move to introduce the other 2 presenters, and then we'll invite Dr. Inman to the podium. We have Dr. Nigel Haroon, and if you wouldn't mind giving a wave to everybody. So yeah. He is the head of the Division of Rheumatology at the University Health Network and Sinai Health. He is an associate professor of medicine and rheumatology at the University of Toronto and a senior scientist at the Krembil Research Institute and the Schroeder Arthritis Institute, a state-of-the-art research facility here in Toronto. Dr. Haroon is an internationally renowned clinician scientist in the field of AS. He is well published in this area and has been an invited speaker in several international meetings. Dr. Haroon also served on the board of the Spondyloarthritis Research and Treatment Networks. We call that SPARCC for short. There are a lot of syllables and a lot of words here, as well as the medical and scientific advisory boards of the Spondylitis Association of America and the Canadian Spondyloarthritis Association. Dr. Haroon has won several awards, including the Vanier Scholarship and Jane Bruckle Award of the Spondylitis Association of America. We are in very good company tonight. I also want to welcome Laura Passalent. Laura obtained her Bachelor's of Science in Physical Therapy from the University of Toronto and completed a Master's of Health in Epidemiology and Community Health at the University of Toronto. She is a certified advanced practitioner in arthritis care. Laura's research focuses on the rehabilitation and education of spondyloarthritis population, as well as innovative health services delivering by rehabilitation professionals. Her research has included the development of a physiotherapist screening program for spondyloarthritis and the development, implementation, and evaluation of an interdisciplinary education program. So thank you to the three of you for joining us here today. I'm now going to shift over, and we're going to shift some slides over right now and invite Dr. Inman to the screen.
Can I just move this? Thanks.
Welcome. Ideally, this would be as interactive as possible, recognizing that the majority of the attendees are virtual, not live. Nevertheless, try to make sure that we've got time for questions, and we'll have enough structure, I think, that to have get the discussion going. But in many ways, one of our key goals is to listen to your concerns and your questions. So we'll make sure we try to address those as we go along. As mentioned, I have the very good fortune of working with Nigel and Laura, from whom you'll hear. It's a privilege to work with such an outstanding team. So Just a few general comments about how we think about how rheumatology is evolving, some of the challenges that we face in appropriate time to diagnosis, and once we get there, appropriate a logical and effective treatment algorithm we can use. So just to remind ourselves that although ankylosing spondylitis is the focal point of the discussion today, it's very much a part of a multi-organ disease spectrum, and as a result, it's multidisciplinary. So we work very closely with gastroenterology. About 10% of our patients have inflammatory bowel disease. Can we get the pointer here? No. Yes, that'd be okay. So that's a strong association. Yep. And then ophthalmology, perhaps the most common non-articular feature of the disease is anterior uveitis, so ophthalmology. Certainly dermatology, about 10% of our cohort have psoriasis. So all of a sudden, what started out as a fairly narrow focus on rheumatology becomes very much a multidisciplinary treatment strategy. A couple of points on this slide, besides the skin, eye, and gut features, are really the juvenile onset. So that's an important aspect. About 20% of our patients have the onset of their disease in their teenage years or even grade school years. And they would start off at sick kids and then move over to Toronto Western when they turn 16. The other group here is reactive arthritis, which is an arthritis triggered by an infection. That's a very interesting group of patients, that some of whom actually evolve into full-blown ankylosing spondylitis. So this is the way that we kind of can clinically see this, a very broad spectrum of disease, but the heart of which is patients with inflammatory back pain. But just keep in mind that comprehensive centers, and we have the very good fortune of working very closely with gastroenterology, ophthalmology, and dermatology at University Health Network. It's a team approach, very much so. Again, jot questions as we go on. I hope this will generate. So when rheumatologists talk about ankylosing spondylitis, that's still the terminology we use. It's actually anchored in a definition that goes back to 1984. And this has served us well in many ways. It's served as the diagnostic criteria for most randomized controlled trials with biologics, for genetic studies, and in many ways it's served a very useful purpose, but it's also raised some questions. So basically, these criteria are anchored in a clinical event, which is usually back pain, at least 3 months duration in somebody less than 45, and it's got some features that sound a little more inflammatory, like it improves with exercise, not with rest. But the key thing is it actually includes an X-ray, a diagnostic element that includes an X-ray. So as it says at the bottom here, when the rheumatologist is looking at an AP pelvis X-ray, we score the degree of change in the sacroiliac joint, the base of the spine. So many of our patients know exactly where it is because it's often the primary source site of pain. But we have this grading system, and that has led to a concept that if you have advanced changes, what we call, let's say, a grade 3 sacroiliitis on a scale of 4, you're kind of more confident that that's the patient, this back pain represents ankylosing spondylitis. Less than that, like less of scoring 0 or 1 is non-diagnostic. So the problem is that the scoring of the sacroiliac joint, and I think the patients here, we've often sat in our clinic with our patients looking at X-rays and discussing some of the complexity about it. The sacroiliac joint just anchors the spine into the pelvis. It's not actually a moving joint, and it's actually still a bit obscure why that joint should be the target joint for inflammation and spondylitis. But the consensus scoring, even if you get, as we have some expert radiologists here at the UHN, and put them together with the expert clinicians, you'll see quite a bit of diversity about the scoring of the sacroiliac joint. That's point number one. The second issue is that basically when you think about the construct here, we're waiting until some damage has occurred to make the diagnosis. Now that doesn't really make a lot of sense when you think about it, right? We don't want to diagnose, we don't want to wait to diagnose lupus until the kidney function starts to decline. And in fact, even in rheumatoid arthritis, we don't depend on demonstration of damage in a joint before the diagnosis is made. So this has created, in a sense, kind of an imposed delay to time to diagnosis. Well, that's one reason. And that's been the case. So this is data from the Spondylitis Association of America, a questionnaire we did, in which we asked the membership, so tell us how much, look, from the time of the onset of your back pain to the diagnosis, how long did it take? And you can see that at least half of the patients had at least 6 years of symptoms before the diagnosis was made. So that's really a problem. And for the patients in the room, many of them can relate to that, because in that interval, you might be seeing chiropractors and massage therapists and all kinds of spine surgeons, all kinds of specialties that are not really getting at the heart of the problem. So we still have a significant challenge. And this is one of, Laura's taken an extraordinary leadership role in this, of how we can actually move that needle back. Like, why do we have an imposed 6 or 7 year delay in diagnosis when you don't really see that in a disease like PSA or rheumatoid arthritis? So Laura's done a wonderful job, and she will come up in the discussion, but it's really a model of care challenge. We have diagnostic criteria that seem to impose a necessary lag time if we're waiting for X-ray changes to occur. And we need to kind of think outside the box about how we can triage patients more effectively. And Laura's really done an outstanding job at rethinking that. So here's the problem, as we said. So if we wait on the right-hand side till X-ray changes have occurred here, yeah, so that's going to impose a certain time, months or even years, before you actually see the X-ray changes, right? So this is not, and during those intervening weeks and months, patients are very symptomatic. They're waking up with morning stiffness, they got fatigue, they have pain, and there's a long lag here. So part of that is that the diagnostic criteria have been dependent on the demonstration of damage, which seems a little illogical. So obviously what we want to move that time frame back. And part of the issue is Laura's leadership in really thinking about novel models of care. Instead of having, for example, the physician as the center point, we can actually bring in much more broad range of allied health professionals into a meaningful triage or screening mechanism. The other is the advent of new modalities. So the X-ray, as I mentioned, the diagnosis of AS is still anchored in an X-ray, but there are a lot of things occurring long before the X-ray changes become apparent. And that's where MRI has been a huge contribution. So as you can see on this image here, at the time, by this X-ray here on the lower left, which is occurring long before the diagnostic changes, are normal. But at the time that X-ray was done, an MRI was performed, and it shows significant inflammation. So these white patches along the sacroiliac joint actually represent active inflammation. This has been a big contributor, because in former pre-MRI, if the X-ray was normal, we said, well, your back pain can't be coming from ankylosing spondylitis. We now know that back pain from spondylitis can occur with normal X-rays, and the MRI is very, very informative. So by convention, you can see here that ankylosing spondylitis occurs if you meet these certain radiological criteria. But what about these other patients that really don't have that? And we've got this rather bulky term called non-radiographic Axial-SPA. So if you might have run into that with your physician, your rheumatologist, it's not a great term. It's kind of confusing. In many ways, if we think of it as MRI positive spondylitis and X-ray positive spondylitis, it's a little tidier, but this terminology is actually in the literature now. And in fact, the change in terminology really is to include radiographic Axial-SPA instead of AS. So that's kind of working. So their paradigm looks something like this. You have a patient in the lower left corner there that may just have a positive B27. They've got a lot of back pain. But then at a certain point in time, the MRI becomes diagnostic. It changes, at which time the X-ray may be totally normal. And then subsequently, there's X-ray changes in the pelvis, sacroiliac joint, and finally, there's spinal involvement. So this is the trajectory over time that we're trying to prevent and try to move the diagnostic needle to the left, farther upstream. So there's some challenges there. And I'm sure in the question period, we can really think together about this, because I know that if you look at referral patterns, particularly in the United States, if you take young individuals in their 20s and 30s with chronic back pain, rheumatologists are not the most common referral site. They see all kinds of different specialties, spinal surgeons, general surgeons, chiropractors, massage therapists, etc. And we would like to strategically get those referral patterns more well-defined. So I'm just, Sherry Rahaker in London is actually just updating the Canadian CRA SPARCC recommendations for the management of SPA. So I'll just give you some highlights here. The advent of the new biologics, for example, what we call the JAK inhibitors, is changing the landscape a little bit. We can see here that the principal component here in approaching management, it has to do with exercise, physiotherapy, and support. It's really critical. Not to say that doesn't apply to other rheumatic diseases, but in axial spondyloarthritis, or AS, we do think that there's solid evidence to support the benefits of exercise and physiotherapy. And again, Laura's played a real leadership role in that. So we always begin that discussion. We have patient support group, and education is very important too. You know, a young person that comes in and Googles spondylitis and see people with bamboo spines, it's kind of intimidating to see that up front. And so a lot of us, we work together with our patients to really try to personalize the management of that individual. So NSAIDs are the anchor. And there are some number of patients we think that have ankylosing spondylitis and respond very well to NSAIDs. We actually, as in physiotherapy or rheumatology, may not see those patients. So we tend to see the patients that have not had a good, satisfactory response to NSAIDs. One common question we get in the clinic is, do I have to take my naproxen and my ibuprofen every day, or can I just take it when I feel I need it? So this study from our colleagues in Berlin compared patients that took the NSAIDs, this happened to be diclofenac or Voltaren, on a regular basis every day, independent of symptoms, and compared it with a group that just took it when they felt they needed it. And the question was, is there a difference in the disease progression? And this curve is, each dot on this curve represents a patient, but the overlap of the two indicates that whether you take your NSAID on a regular basis or just as needed, it didn't affect treatment and radiographic progression over time. The other important dimension about the NSAID discussion is that we recognize that treating NSAIDs carry significant potential side effects. We've been well aware of that from gastroenterology, from peptic ulcer disease and gastritis for a long time, but increasingly recognize the effect on blood pressure, renal function, and even heart attacks. So there's been a great deal of discussion looking to the extent to which drugs like the biologics actually may offset some of the negative adverse event of taking NSAIDs indefinitely. So it becomes an important part of the discussion. And a very important study that Dr. Haroon led showed that patients with ankylosing spondylitis have a higher than expected frequency of heart attacks and even stroke. So when we have a discussion about long-term NSAIDs and their safety, it becomes a really important issue there. So unlike this treatment algorithm is a little different than rheumatoid arthritis or psoriatic arthritis, where it includes what we call the conventional disease-modifying anti-rheumatic drugs like methotrexate, for example, leflunomide. Spondylitis is a little different because most of those drugs don't affect spinal arthritis. So you can see here that if there's what we call peripheral disease, drugs like sulfasalazine and methotrexate come in. But most of our patients in our clinic, if they have not responded adequately to NSAIDs, and they primarily axial, that is to say spinal disease, the next stop really is to have a serious discussion about escalating therapy, when to escalate therapy to a biologic. So there are broadly three broad categories of the biologics available to us in Canada. These are the 5, what we call TNF inhibitors. 4 of these are monoclonal antibodies. One's a soluble receptor, that's Enbrel. 4 are given by subcutaneous injection. One's given by intravenous infusion, that's infliximab. And these drugs have changed the landscape dramatically. In Remicade and Enbrel came on the market about 1999, 2000. So we're well past 2 decades of the use of this class of drugs. So we've learned a lot about their safety and efficacy, which has really changed the landscape. The outcome measures in these studies, just as a word in passing, are really anchored in patient-reported outcomes, right? So there's subjective sensation reported by our patients. And so that's an important dimension. And I would say the primary outcome in most of these studies has to do with pain. Like what has there been a substantial and clinically meaningful change in pain? So if you look across in Canada, there are 5 TNF inhibitors on the market. And although these are not head-to-head comparison, the comparable height of these bars shows that whether it's infliximab, etanercept, adalimumab, golimumab, or sudocetaxel, they're all pretty comparable. And I think that's been the general consensus, that these, with respect to spondylitis itself, there are comparable levels of efficacy. It becomes some of the questions that may rise in the questions is how you actually decide then about which biologic you're going to select. But just in terms of effectiveness, they look very comparable. In terms of this other interesting group called the non-radiographic group, that is patients with MRI positivity but X-ray negative, we also have data here too for the other TNF inhibitors. So on both aspects of the spondylitis spectrum seem to be very comparable to these drugs. And this is a study that, published from the British Registry of Biologic Agents, large registry that includes all the UK patients with spondylitis. And if you look at response rate, whether it is ankylosing spondylitis or this non-radiographic subset, it was very comparable. So that's good news. So we know from these early trials that it improves pain, it improves function. But the question was whether it really changed progression. This was a study that Dr. Haroon led with 4 centers in the United States. And it really showed that if earlier intervention with TNF inhibitors not only improves symptoms, it actually improves the natural history of the disease. So this was that's been an important discussion, right? Because if we now, the bar is set a little higher, not only symptomatic improvement, but modification of the long-term outcome over the coming decades becomes part of the goal and try to prevent the development of bamboo spine. So the next class then was what we call IL-17 inhibitors, of which there are 2, now 3 in the market. And this was a study that looked at patients that are TNF inadequate responders. So these are patients that might have had Embra, like Humira, and lost or did not have an adequate response. And biologic naive patients, like first biologics. And the encouraging thing here for the rheumatologist was that now we had a second class. If a patient had lost their response to a drug like Humira or Remicade, now there was a second class that could actually be looked at. When you look at the IL-17 blockers, this happens to be secukinumab, compare with adalimumab, which is a TNF blocker, the 2 classes. They seem to be very comparable in clinical response, and even the effect on X-ray changes also looks quite comparable. So that's a good thing to remember. The X-ray changes move very slowly. We can use an MRI that we've used for diagnostic purposes also as a clinical outcome. And the MRI responses that show decreased inflammation in the sacroiliac joint are very comparable between the TNF inhibitors and the IL-17 inhibitors, which is great. So this is true also for patients with non-radiographic AS, so that we're not looking at X-ray changes in the spine. We're looking primarily at symptomatic improvement. This happens to be secukinumab, an IL-17A blocker. And if you include head-to-head an IL-17 blocker and a TNF blocker, it's hard to see, but right in the middle bar of that, it happens to be that circle there, adalimumab, they seem very comparable. So again, from the clinical response rate, IL-17A blockade seems to be very comparable to the TNF blockade. And this is true for ixekizumab, which is a very close cousin of secukinumab. One of the issues that comes into the discussion may come up in the questions is what are the relative differences? So IL-17 blockade looks very effective and comparably effective for spinal disease. And it's very good for psoriasis, Whereas uveitis and inflammatory bowel disease is a little different story. IL-17 blocker trials in Crohn's disease were not found to be very effective at all. And the uveitis eye inflammation question is outstanding. So some of the issues that come to bear on this discussion really have to do with what they're doing with the other features of the disease, like the inflammation in the GI tract and the skin and the joints. So second, one of the questions there is, if you block 17, which doesn't work in inflammatory bowel disease, are you going to start seeing more of that in the AS population? And it seems not to be the case. The last class, the most recent ones on the team are what are called the JAK inhibitors. This is Xeljanz tofacitinib that was reported and showed very nice changes. So the lower curve here is the placebo arm up to week 16. So patients that started on tofacitinib, these are oral instead of injectable, very attractive to many patients. And once the placebo group crosses over to the active drug, it catches up very quickly. So this is the very encouraging that the oral JAK inhibitors were part of the armamentarium. This is another JAK inhibitor called upadacitinib or Rinvoq. And you can see here that when we're scoring patient-reported outcomes, it clearly is making a substantial, much more dramatic difference than placebo. So two versions of the JAK inhibitors look very, very successful. And even if patients had been on a 17 blocker, a TNF blocker previously, they seem to respond really nicely. There is an issue, just for completeness. Cardiovascular risk and JAK inhibitors have been in the news, and certainly there's a concern about whether they carry a higher risk of cardiovascular complications. The study that anchored those concerns had to do with elderly patients with rheumatoid arthritis. At the moment, it's a very important part of the discussion, but happily in our case, and most of the most recent data seems to suggest that is not confirmed. The observations of rheumatoid arthritis for cardiovascular risks have not been transferred over. So that's I'll turn to Brenda now. I hope that there's some questions. If not, we can hold them to the end. But it's kind of a snapshot of our thinking of overview of the treatment goals of spondylitis. The short-term treatment goals are symptomatic, to improve the pain, stiffness, and fatigue of spondylitis. The long-term goals are to prevent disease progression of the spine over time. Madam Chairman?
We have a few minutes. We have a few minutes for some questions. I know that there are some online, but I wasn't sure if there was anyone in the room that had a question.
Any questions here? Okay.
So where we had some that were submitted, question from Debbie. I struggle every day with pain and mobility issues. I work a casual job and I'm finding it really hard to work. I was thinking of going on CPP, but I would like some advice.
Well, so this is a big issue about what defines disability. I mean, we're happily most of our government and private coverage for disability or CPP, for example, it's a big decision for a lot of patients. They're stepping away from a career or their source of livelihood, source of revenue. There's good evidence that if you look at timely and appropriate intervention with biologics, you improve work performance. So this has to do with, and getting people back to work or staying in actively participating in the workforce rather than dropping back to a disabled status. So the short answer is there are no question. There's some patients where, despite our best efforts of early diagnosis and treatment options, that patients are left with significant disability. But we would like to, in most cases, that's ideally the path of least employed. We really want to, and using the data from the biologics about improving work performance and performance in the workplace does suggest that if we can intervene effectively at the right time, we can minimize the trajectory to disability.
That's great. Thank you for that. I'm going to move into another question. This question is from Evan. What to do when doctors don't validate your injuries or pain?
Good question, Evan. I mean, so it's a complicated, it's an important question, because if you go to a doctor, whether it's with toothache or back pain, first off, the pain, we all hope as patients, we've all been patients in some sort of one, that the clinician you're encountering, whether it's a physiotherapist or a surgeon or a rheumatologist, is taking your complaints seriously. So if the question is it not validating, I think the question is the physician in question hearing the complaints appropriately? I would say, kind of as an aside, at the level of the primary care physician, so back pain constitutes one of the commonest problems that a primary care physician sees. Primary care physicians have high volume clinical practices, right? They have a short little window to see a patient quickly. And somebody comes in with a kind of an obscure history of back pain. This is not in defense of the delay in diagnosis, but it helps us in retrospect realize that some very capable clinicians might miss the diagnosis early on. Because most young patients coming in to see a primary care physician with back pain do not have spondylitis. They're going to have a mechanical source of the back pain, like degenerative disc disease. That doesn't in any way excuse the pain not being attended to and validated. But I think in the context of the healthcare system, where back pain is such a huge problem, and we, in the screening modules that we're working on, the improved models of care, are how to more effectively identify the source of the pain in a timely manner. But I can hear the question, Evan, behind your frustration.
And we have several other questions. We'll go into one more before we switch over the slides. And this question is from Jean. Does AS and its biological treatment affect your memory? I feel like I can't remember or process things anymore.
So that's a good question, Jean. In fact, we had a session today with our neuroscientists. So some of our colleagues in this building are neurologists focusing on living with chronic pain. And what they find is that your attention to activities and tasks at hand is profoundly affected by pain. It actually works both ways too. If you're distracted, your attention to pain. But so that's relevant because that tells us these are brain imagery. These are people that are thinking about the brain and brain function, brain fog, brain fatigue, and even including brain imaging. It's pretty clear from the pain experts that living with chronic pain impacts your cognitive performance. It distracts you. You're not at the top of your game. If you're working on a computer job that requires a lot of mental agility and your attention is distracted to the stiffness and the pain in your back, it's going to affect your performance. So I think that is a reality. And I think one of the benefits that we see in the clinic is when you identify the right drug for the right patient, and this would be, for example, if the pain is actually attributable to chronic inflammation, coming in with an effective biologic, one of the first things they say is that they're focusing, but it's not just the pain has gone away. They're energized, they've got energy, and they're functioning much more effectively in the home and in the workplace. So it's an important dimension because pain is a centrally perceived issue. And so and we know that it's very closely allied with the depression and anxiety that can go along. Living with pain can also have a secondary effect on our thinking and our cognitive function. So it's a really important aspect of the disease.
Thank you so much, Dr. Inman. And we'll get to all these other questions a little bit later on. We'll call on Dr. Haroon, please.
Yeah. Okay, thank you very much. And thank you for coming in today for this in-person event, and for all those who are online. I know the weather was not great outside, but still you made it here. My role is to give you an update on what we have regarding the understanding of why this disease develops, what the immune mechanisms behind this disease are, what is driving it in terms of progression, as well as onset of disease. So I've got a few data-rich slides. The idea is not to really, go through all the immunology and everything, but just to give you a hint of where we are headed, and hopefully in the near future we'll have more solutions than questions. So these are the 4 broad areas I want to cover today. So talk maybe a couple of slides on what the genetic predisposition to AS is. A few more slides and details on what the exact role of HLA-B27 is. This is a term which you have all heard, I'm sure. Throw some light on what are the non-HLA, because there are many other genes that are associated with this disease, and finally end up with some points on the non-genetic factors that are important. So when we talk about the pathogenesis of any disease, we always consider 2 major categories or driving forces. One is genetic, and the other one are environmental factors that influence this disease. And clearly what is implied by this figure is that the genetic factors far outweigh the environmental factors, which is our current understanding. But I wouldn't be surprised if in a couple of decades I'm proven wrong. And there are many reasons why I'm thinking in those directions. And I'll come to that in a bit. So the earliest indication that ankylosing spondylitis is a familial or a genetically driven disease came from twin studies. So if you look at this table here, this is a comparison of the concordance of disease in pairs. The first column is for monozygotic, MZ is monozygotic twin pairs, and then you compare it to dizygotic twin pairs. So monozygotic means there is greater gene sharing coming from the same zygote. And you'll see that the concordance with both twin pairs being affected is 50% if it's a monozygotic twin pair compared to dizygotic twin pairs, showing that greater gene sharing, greater chance of concordance of disease. You can look at families and look at the degree of relationship, and you'll see that as the degree of relationship becomes closer, the chance of getting the disease in the family or in the relative is much higher. And you can see here, this is a good number to take. If you look at 1 there, that's a first degree relative. So parents, kids. So first degree relative, the chance of recurrence of the disease is roughly around 10%. So a question that a lot of patients come and ask is, so I have this disease, what's the chance my next generation, my kids will develop disease? So the rough number is around 10% chance only. Or in other words, 90% chance that the next generation will not be affected by this disease. So HLA-B27, this is one of the most commonly done tests in ankylosing spondylitis. What is HLA-B27? The most important thing to remember is that HLA-B27 is not equal to ankylosing spondylitis. And the reason why I say that is because if you test HLA-B27 in every Canadian, 7 to 8% will come back as positive. But the disease is present in less than a percentage, right? If you have 100 people walking into the clinic, and we have a lot of people walking into the clinic with a positive HLA-B27, only 1 or 2 walk out with a diagnosis of ankylosing spondylitis. So 98% of people with an HLA-B27 do not have the disease. And the reason is because HLA-B27 is just a normal gene. It is present in our system to protect us from infections. So what does it do? Just to make you understand what this gene does, let's take a look at an antigen presenting cell. Okay, and suppose we get exposed to a virus. Let's take that as a flu virus going by the season. And what happens is that an antigen presenting cell will take in the virus. It'll break it down because the cell is not capable of recognizing the entire virus because it's too complex for a single cell. It'll break it down into small parts, and that's what you see there. These are small parts of proteins called peptides. Now, this peptide has to be recognized by our army of T cells. And again, it cannot recognize these peptides if it's just floating around. It has to be presented on a plate to the T cell. And this is not coming out well, but Imagine that is a plate, a server presenting that peptide. It will take it to the surface of the antigen-presenting cell, and the T cell is now ready to recognize it. The T cell will come, recognize this, okay, this is a flu peptide. This guy is not good for you, so we'll get rid of it. How does it get rid of it? It'll get rid of the entire cell that is carrying the virus. So B27 is just doing a normal function. And to give you one or two more examples, HLA-B27 positive individuals, if they get HIV infection, very few of them progress to AIDS because the peptide from the HIV virus can be presented efficiently on B27 and you mount a good immune response. So it's natural protection. Another example is if there is hepatitis C virus infection, very few of those who have a HLA-B27 will go on to develop cirrhosis of the liver because hepatitis C also is well presented like that on B27. So it's just a normal molecule there that is doing its normal function. But how does it play a role in ankylosing spondylitis and what is the happening there? So maybe HLA-B27 and this interaction that you have there has somehow gone abnormal, leading to ankylosing spondylitis. So it's always to explain disease, we always go to animal models. So let's take a look at one of the animal models, the most famous AS animal model, which is the HLA-B27 transgenic rat. So what was done here is that rats, in regular rats, you take human HLA-B27 and introduce it into the rat and see what happens. They start developing arthritis, nail changes of psoriasis, skin changes of psoriasis, and gut changes of inflammatory bowel disease. And just by adding HLA-B27, all of these changes are happening, which shows that B27 seems to be important. However, it may not be sufficient to cause disease, and that's why 98% of people are normal carrying the HLA-B27 without developing the disease. Now, how is HLA-B27 leading to ankylosing spondylitis? We still don't know. The discovery happened 50 years ago. This is the 50th anniversary, 50th year anniversary, and we're celebrating it with a lot of conferences and workshops around the world with the same question we asked 50 years ago. What does HLA-B27 do? I don't think we have a complete answer yet. But of late, there have been a lot of advances because only thanks to technological advancements. So we have a much better understanding now. So one of the mechanisms probably is that, just as I mentioned, it is an antigen presenting molecule. So on the surface of the cell, it may be presenting some antigen, which we don't know, maybe some antigen that predisposes our body to develop an immune response. And the immune response manifests by attacking the spine, the joints of the spine, the eyes with uveitis, maybe the gut with inflammatory bowel disease. That may be a cross reaction to that antigen. Another peculiarity of HLA-B27 is that it accumulates inside the cell. When it accumulates inside the cell, it causes a lot of stress. And as we all know, nobody likes stress, right? And so what happens? It becomes very pro-inflammatory, starts producing a lot of cytokines, and it starts attacking the joints and other tissues, leading to an inflammation. And finally, B27 is also very different from other HLA alleles, HLA molecules, because it can malform or accumulate in abnormal forms on the surface. And now the body is finding a normal molecule in the body, but in an abnormal form. So it thinks it is something foreign, and it starts attacking the cell only because the shape has changed. And that also can lead to abnormal immune responses. So all of these things we are hypothesizing only because we know that B27 is capable of all of these things. But what exactly is behind AS, we are not very sure. Okay, so what is the clinical impact of HLA-B27? So if somebody, AS patient is HLA-B27 positive, there's not a lot of difference from an HLA-B27, if somebody's HLA-B27 negative. So people have looked hard, and some of the findings that are there is the spinal fusion tends to be slightly more worse if you're B27 positive. The other evidence is that in the familial concordance seems to be slightly higher if they are B27 positive compared to B27 negatives. Other than that, there are really not a lot of difference that you can find between B27 positive and negative. So what's new? As I mentioned, because of technological advances, we have been able to narrow down on what is perhaps driving this immune response. So we talked about the antigen being presented on the surface with no clue what the antigen is, but modern technology, and this is a study from Dr. Inman's group here. So what he did was he took the surface T cell receptor and he tried to clone it and sequence it and find out what exactly is it recognizing. And this initial paper, what it showed is that, and I'll show you just one, it's not a complex figure at all. I'll take you through this. The idea is that if there are millions of T cells that are circulating in our body, right? Because we are exposed constantly to multiple antigens and we need to be ready for everything. But if, let's say, 4 or 5 different antigens are being recognized excessively, that means we are being exposed to these 4 or 5 antigens excessively. And if you look at the T cell sequence in AS patients, you see that some T cells are much more common than other T cells, which means that in our body, we are constantly getting exposed to this antigen, and that may be driving the disease. And that's what you see here in the black bars. In B27 positive AS patients, you have more selection of these T cells, indicating again that maybe something is driving the disease. You take it one step forward, and and this is the most recent paper. It's a Nature paper that has come out with I don't know, maybe 50 authors in it or so, coming out of 3 or 4 continents. It's a very large study, and I'll sum it up into just a couple of slides here. One is, what they did is they took peripheral blood from AS patients. They also took eye fluid from the uveitis patients, and they sequenced the T cell and looked for what is the antigen driving it. And they actually found a few antigens that is common between the eye inflammation and the peripheral blood, again proving that maybe there is an antigen driving it. Now here's the key slide, and you have to all memorize the next slide because that's what's going to come in the exam at the end. All right, so you can write down anything in the paper except A, B, C, D, E, because you just have to mix it up. Just A, F, D, and C and all, right? Never write in sequence. But this is just to show you that despite all of these technological advances, we still are not down to 1 or 2 antigens. So all of these are potential antigens that can sit on the sequence that we have found in AS patients. So we're coming close, but not yet. And there may be a reason again. Maybe it's not just one antigen for everybody. Maybe it could be a flu virus for somebody. It could be something else for somebody else. It could be an endogenous antigen for others. Maybe you get a trauma and our own antigens get exposed. That also is possible. We just don't know yet. Now, this is what I explained. Only 2% of B27 positive individuals actually develop disease. So in search of the other genes, the genome-wide association studies were done, and a bunch of genes popped up that were found to be important in ankylosing spondylitis. And you can take a look at this table, which lists the top hits. And you can look at the column number 3 there, which shows the odds ratio of these genes. You'll see that HLA-B27 has a number of 90. And after that, it's dropping drastically to just above 1. Which shows that B27 is really the only major driver of disease. Everything else has a very, very minor role. So perhaps you need 10 different genes to get abnormal before the disease develops. And that's probably why only 2% develop disease, because in the 98% of individuals, most likely all the other genes are not pro-arthritogenic or are not arthritogenic. So that might be the reason. And also, if you add up everything, you can look at the total at the end. The heritability risk is only around 25%. So despite all these advances, we are able to explain only around a third of the heritability that we see in families. So maybe it's not just in the genes. Maybe there is something that we are commonly exposed to within the families. It may be the environment, it may be the food we eat, it may be the microbiome. So there may be other explanations for why this disease develops. So that Venn diagram approach initially, maybe the size of the genetic circle will become less and environment may become more. We don't know that yet. Okay, this is, I'm going to show you over the next few slides, 2 or 3 examples of how other genes can be involved. And here is ERAP, and this is an interesting molecule. The other day I had a patient who came in with a 23andMe report and said, I have a AS. So I looked left and right. I couldn't find AS and any evidence of AS. It's already seen in 2 or 3 other physicians. They also said no AS. And then this patient pulls out the report and says, look, I have an ERAP polymorphism, which is associated with AS. So I have AS. So again, if you go back to remember that table, the ERAP polymorphisms, it's a very well-known gene now in ankylosing spondylitis, probably only lower in importance only after B27 and IL-23. However, the changes that you see in the gene in the genes that are associated with AS is seen in 35 to 40% of normal individuals, right? It has a very, very small role, but an important role. And I'll just explain what this role is here. So let's take an example. So this circle there, it's a protein from, let's say, a virus, and that gets broken down into the peptides. It gets into the cellular endoplasmic reticulum, and it gets broken down by ERAP. So what the ERAP is essentially scissors that trims down the antigens for presentation on B27 to the surface. So now if you have B27, but you also have an abnormal ERAP1, so now you bring in an abnormal gene, second gene into this pathway, then you can see that instead of a properly folded peptide B27 there, you have an extension, a few extra yellow dots there. So now B27 has a peptide which is abnormal, and that can lead to more instability. You can more abnormal surface expression, more collection within the cell, more cellular stress, more inflammation. So all of these things can happen because in addition to B27, the processing was abnormal because ERAP is also abnormal. So that's a second hit that may be leading to disease. So this just to show you how multiple genes can come together. If you take this one step forward, what does this discovery really mean? So what was seen was that the genetic change associated with ERAP in AS was associated with increased ERAP function. So the first question that people asked was, can you reduce ERAP and cure AS, or reduce ERAP and treat AS? So the best example, again, we move to an animal model, right? Here you go. So you have arthritis in the B27 positive transgenic rat. You get rid of ERAP in this transgenic rat, see the arthritis goes away. So it's a very interesting model, and I was honestly very surprised because you consider the very small effect of ERAP1, but in this animal model, you get rid of ERAP, the arthritis improves. But the story doesn't end there. Take a look at this. This is the colitis. You take out ERAP, the bowel inflammation actually goes up, increases. So the arthritis improves, but the bowel inflammation is worse, which again shows that there may be different mechanisms, maybe the same players, but different mechanisms in the eye, in the bowel, in the joints. And that may be the reason why when you treat patients with some molecules, sometimes the bowel responds, sometimes the joint responds, sometimes both respond, but not always same and the similar, right? So that maybe because of different mechanisms. And the last, I think, gene-related slide I want to show you is this model. So we talked about the T cells recognizing antigens. We talked about B27 presenting these antigens. We talked about ERAP. One thing which we didn't talk about is the autophagy and all of that, which we can completely skip that. But we did talk about the stress. What we haven't talked about yet is how does this B27 peptide complex go to the surface? I told you it goes to the surface to get presented. But how does it happen? It happens through the cellular trafficking mechanism or through the Golgi apparatus, and that has to happen through that mechanism. So here is where I would like to introduce you to a multiplex family, or a family with multiple AS members involved. And this is from Newfoundland. So our SPARCC investigator, Dr. Proton Rahman, our collaborator, has been following this family for many years. And what is interesting is that 9 individuals in this family, it's a very large family, 9 individuals who had both HLA-B27, you can read in the second line, who had both HLA-B27 and an abnormality in the gene called SEC16A. All 9 individuals developed AS. So it's the first time I've come across something like this, where there is 100% penetrance of disease. So B27 plus abnormality in the gene. Initially, when we published the paper, 7 out of 9 had disease, and the 2 who did not have disease were around 12 years and 14 years or something. In the subsequent 2 to 3 years, all 9 developed disease. So this we were really intrigued by how this came about. So we talked about B27, ERAP2 genes coming together and causing abnormalities. Let's add a third player in there. So this B27 goes to the surface. It has to be presented. Remember the Golgi apparatus? And that happens because B27 gets into a vesicle like that, and it's transported in the vesicle. That vesicle buds out from there, and SEC16A is actually involved in this budding process. So now you have B27, you got an antigen, you got ERAP that trims it down, and now you got, and finally SEC16A that brings it out to the surface. So multiple parties, B27, antigen, ERAP, SEC16A, 4 players together in the same pathway. And you can actually measure this by doing just staining the area. You don't need to, it's just to show you that you can actually quantitate this. And here is an example. So these are cells from the family members with disease and without disease. You can see that if normal individuals will have these very nice areas where the B27 can come out. And if the family members who did not have the SEC16A normal SEC16A, it was all dispersed throughout, and they could not bring B27 to the surface. And this is all quantitated here. And what it resulted in is lower, as an example, lower flu vaccine response, because the B27 was not coming to the surface. It was not presenting the flu peptide. It also resulted in significant more inflammation and stress in the cell. Okay, so I think in the interest of time, I'll just skip that. The final part is the gut and whether everything starts in the gut or not, and microbiome related changes have been reported. So microbiome related changes can be recognized by our cells, leading to activation of T cells, leading to inflammation. These activated cells can go into the bloodstream, and through the bloodstream, you can see all these cells have been identified in the bloodstream, and they can end up in the joints. If you take the fluid from the joints, the same cells can be identified. So there is a possibility that the antigenic exposure may be happening in the gut. The microbiome related changes lead to activation of cells. These cells go through the bloodstream and end up in the joint tissues. So that's one more thing to understand. Now, apart from these genetic and immune related changes, one thing that has been proposed by several groups is the role of biomechanical stress, right? And a classic example is plantar fasciitis. Plantar fasciitis, I know many of our patients suffer from plantar fasciitis because plantar fascia is a place where the muscle gets attached to the bone, the tendon gets attached to the bone, and it's very prone to develop inflammation. The problem is that plantar fasciitis is so common. It can happen even if you walk a lot without proper footwear. It can happen in normal individuals. But similar to plantar fasciitis, wherever the tendon attaches to the bone, that area is called an enthesial site. It's a very special kind of tissue that is very prone to inflammation, and especially so in spondyloarthritis like AS and psoriatic arthritis. So where there is a lot of biomechanical stress and these enthesial sites are prone for that, you get a lot of inflammation. And here is an example where you can see significant inflammation, and this is just an example of a TNF overexpressing mouse where there is a lot of inflammation. And if the mice are suspended by the tail, okay, you don't let the mice walk on in their hind paws, you can actually reduce the inflammation and bone changes in the hind paws, which shows that if there is a lot of biomechanical loading, inflammation can set in. The exact sequence of events is not very clear, but there may be antigenic exposure that is happening because of micro trauma in these sites leading to inflammation. And the last slide, which I have for you, is just to introduce you to this new molecule, macrophage migration inhibitory factor. And this is a discovery again from our lab here. It's a novel cytokine. You have heard of interleukin-17, IL-17 blockers. You've heard of TNF and TNF inhibitors. You heard of JAK inhibitors. And this is another molecule, MIF, and we found that it can drive inflammation. It can drive bone changes in ankylosing spondylitis. We have also shown that inhibiting this molecule in an animal model leads to suppression of inflammation and reduction of bone formation. And we think that this is a very prominent target, potential therapeutic target in treatment of AS. And hopefully we'll be able to come up with something in the near future. And that's the group of people who have worked on this project. So I think I'll stop there because we're almost at time. Okay, thank you.
So thank you so much for that. We have several questions, and we have slated to have a 15-minute bio break right about now. But what I'm going to suggest is that whether you're attending virtually or here in person, is that you just feel free to get up and help yourself to, some water, use the facilities, stretch if you need to. And we're going to keep going so that we can address as many questions as possible. So
we'll take it now.
Yeah,
Okay.
yeah. So I have several, and then we'll capture as many questions as possible after Laura. So, is there any evidence to suggest one class of medication works better than another for help me out with this.
Enthesitis.
Thank you. Predominant disease.
Well, I personally don't think so, but again, depending on what disease and also depending on the patient's individual characteristics, it may be different. Again, we all know the relative importance of different factors in our body that makes us select one group of medications or the other. As an example, if there's a lot of eye inflammation or uveitis, I would select a TNF inhibitor. If there is a lot of psoriasis, I would select an IL-17 inhibitor. If it is only enthesitis, will it prompt me to select a specific agent? I'm not sure, but I've seen that especially in psoriatic arthritis, there's a lot of enthesitis. And the physicians who treat a lot of psoriatic arthritis tend to use more IL-17 inhibitors and IL-23 inhibitors, provided there is no associated gut inflammation or eye inflammation in these patients. So it's really a balance, and I don't think there is one right answer. It'll be, what you feel is the right option at that time.
Great, thank you. And that question was from Janet. So thanks, Janet, for that question. I have a question here from Francois. It says here, if I am on NSAIDs, when I have pain, but there is still inflammation, when is it time to consider another option?
Yeah, great question. And again, this is all based on agreed upon standards. Is this based on specific biological evidence suggesting that if you're at this number after these many days, it's the right time to move to the next? No, it's not like that. It's based on expert opinion and based on observational data from across the world. So the current understanding is that if you have if you do a questionnaire called BASTI, which is a patient-reported outcome measure, and if your value is above 4, it is not an acceptable state. And why do we call it not an acceptable state? It may be associated with more progression. It may be associated with greater damage over long term, but that's not really the exact reason why we say a 4 is not acceptable. Because if you have 100 people in the room, you give a BASTI questionnaire to these 100 patients, and they will answer and give it back to you. You give the second questionnaire, and it has only one question in it. Do you feel your level of symptoms are well controlled and is acceptable to you? The vast majority of patients who say it is acceptable and is well controlled will have a BASTI of less than 4. So that's the main reason why we have selected this BASTI of 4 as a cutoff there, right? So the current understanding is if your BASTI is more than 4, and if you have had NSAIDs at full dose for more than 2 weeks internationally, in Ontario, you have to have it for 4 weeks, and still the BASTI remains above 4. There is no point in continuing beyond that period because you're unlikely to have a greater response after 4 weeks. That's the point to make a switch.
Thank you for that. And just as I navigate these questions online, if anyone in the room has a question, Maria is at the back of the room, and so feel free to just raise your hand, and she'll come meet you where you are. I just wanted to mention there are several heartwarming comments here, and one is from Tracy, and she says, "I feel so seen." And validation is quite often an area where people struggle. And I just wanted to say thanks to so many of our supporters here in this room and joining us virtually, because we can't do this without you. Okay, so moving on to another question here from Nick. We know that movement and exercise helps. Can you break down medically what happens to the body, why movement, et cetera, helps AS?
We got the perfect segment coming up with.
Maybe we should park that
yeah,
one.
yeah,
We'll come back, Nick, to that question. Okay. So there, okay. Is peripheral spondyloarthritis treated similarly to AS?
Is peripheral arthritis treated similar to AS?
Yes.
Yeah. So in ankylosing spondylitis specifically, and we call this condition Axial-SPA because the predominant and main manifestation is back pain. But then spondyloarthritis is a spectrum, right? People can have peripheral arthritis. Even those who have adult AS might have started off predominantly as peripheral arthritis in their young ages if the disease started less than 16 years. So if you have primary back involvement or axial SPA, up to 40% individuals can have peripheral joint involvement as well. Generally, all the treatments that you use for axial symptoms and axial SPA also work well for peripheral joint symptoms as well. Now, the difference is if you have primary peripheral arthritis, or just, a classic example is psoriatic arthritis, the peripheral arthritis can respond to IL-23 inhibitors, which doesn't work for back pain or axial involvement. That is where the difference comes.
Thank you for that. I'm going to keep digging into these while we're on our break. Okay. Are JAK inhibitors only taken orally?
Yeah, that, as far as I know, only oral JAK inhibitors. I've not seen anything else on the market yet.
Okay, great. Thank you, Catherine, for that question here. So Calm has a question. Is there a criteria to qualify for biologics? Is there a criteria to qualify for biologics?
Okay. Yes. So what I mentioned before was exactly the criteria. So anti-inflammatories was the first line for treatment for ankylosing spondylitis. There are individuals who cannot take anti-inflammatories. If there is significant inflammation in the gut, for example, inflammatory bowel disease, then they can't take it. They are allergic to anti-inflammatories, they can't take it. Excluding these situations, anti-inflammatories are the first line of treatment. So full dose anti-inflammatories in Ontario, the minimum is for 4 weeks. If you fail the first anti-inflammatory, then you take a second anti-inflammatory for another 4 weeks. And at the end of 8 weeks now, if the BASTI is still above 4, then you qualify for going to a biologic agent. Now, in Ontario, you have to prove the diagnosis through imaging methods, so either an MRI or X-ray, to prove that there is ankylosing spondylitis or axial SPA is required. And the physician interpretation of the images is all that you require. Depending on geographic locations, this may vary.
Great. Thank you for that. Another question here. What potential side effects or risks are associated with biologic treatments, and how are they monitored or managed?
Yeah, this is we are so fortunate to have Sue and her team here as our pharmacovigilance nurse and the full biologic surveillance team that we have here. This is exactly what they do. So earlier on in the early part of 2000s, when TNF inhibitors were the first biologics introduced in the market, everybody was really scared and worried because the name itself of the molecule is tumor necrosis factor, right? It's required for necrosis of tumor. So if you get rid of tumor necrosis factor, all the tumors will start popping up. Was everybody's worry. So, and plus it's an important molecule involved in the immune system. If you're suppressing the immune system, or you could have major infections that happen. But fortunately, over 20 plus years of experience, we now know that most of these biologics are really safe in the appropriate setting. There may be settings where it may not be safe. For example, if there's a lot of contagious disease around, perhaps it's not safe. If you're an individual with already a suppressed immune system, perhaps this additional biologic may suppress it even further. But apart from these conditions, it's a really safe molecule. What we do is, before starting a biologic, we always screen and make sure that there is no underlying chronic hepatitis, there is no pulmonary infection. For example, you do a chest X-ray, you do a TB skin test, and make sure all of these are negative. And once you do these minimum investigations, the chance of getting an infection is very low. Still, there is a 2 times increased risk of minor infections, which is usually an upper respiratory infection or anything. Unless you require an antibiotic, there is no need to really stop the biologics. We continue monitoring almost every 3 to 6 months with blood work to make sure the liver and other organs are normal.
Thank you so much for that. And I think maybe what we'll do is, as questions keep coming in, maybe we'll ask Laura to come on up, and I think your slides are ready to go. So this will just take a moment here for those who are joining us virtually.
So before we get started, I'm going to ask everybody to stand up. I think we've been sitting for a long time. Let's move around. I'm a physio. This is what I do. Important to stand and move, because my talk is all about activity and movement.
You're okay?
Yes. How do I? Where's the slide 1?
Yeah, let's just go to
Okay. And you can put it like, I don't need all this because I can't read it.
Oh, okay. Ready, let's go. Let's go.
Stretch. Everybody online should be stretching out of your seats, moving around.
Okay.
Okay, we're good?
Yeah.
So just get started. Okay. All right. You can stand for this whole talk if you want. Doesn't matter to me. I'm okay with it. Okay. So I'm going to be talking about physical activity. And so over the next 15, 20 minutes or so, I'm going to be talking about what physical activity is, why we need to do it. I'm going to introduce you to something new. It's called the 24-hour movement guidelines. And I'm going to talk a little bit about how we can get moving. And the other thing I just wanted to mention is, in some of the slides, I have this little phone icon, click. So feel free to get out your phones, take a picture, because there's some key information that you might want to go home with. Okay, so what is physical activity? So physical activity is really any bodily movement that we do in our day-to-day lives. So it could be work. Do you have a very sedentary type of job, or do you have a very active type of job? It could be stuff we do around the house, so yard work, vacuuming, that sort of thing. Transportation, how are we getting to and from work? Are we sitting in a car for 2 hours commuting? Are we riding our bikes? Are we walking? It's leisure activity, and it's also exercise. So I'm going to do a poll here in person, but also online. And Brenda, you can help manage that. So it's very low tech polling. So I'm going to ask the group here and online, at a minimum, how many minutes a week should adults between the ages of 18 and 64 engage in physical activity in order to gain the health benefits? A, 50 minutes, B, 800 minutes, or C, 150 minutes. So if you think A, put up your hand. Okay, we got one. If you think it's B, put up your hand. And if you think it's C, put up your hand. Oh my goodness. And what about online? C? Oh my God, this is really good. You guys are right. Okay, so the Canadian Society of Exercise Physiologists, they've put out recommendations and guidelines around the ideal amount of physical activity that you should be engaged in on a weekly basis. And it's a minimum of 150 minutes per week, as you guys mentioned. Good job. Do I even need to do my talk? I don't know. We'll see. Okay, so one of the key things about those 150 minutes is that it has to be at a minimum of a moderate intensity of physical activity. So what does that mean? So that could be a brisk walk, it could be bike riding, but essentially if you're engaged in any form of physical activity and you're sweating, but you're able to maintain a conversation, that's most likely a moderate aerobic intensity. If you're engaged in a form of physical activity and you're short of breath, but you're sweating, you can't have that conversation with your friend that you're jogging with, then you're performing at a vigorous aerobic intensity. All right. Now, the other thing that's important about these physical activity guidelines and recommendations is that we should be engaging in some form of strengthening activities at least 2 days per week. So how many in the room are strengthening, purposefully strengthening, using weights, doing appropriate exercises? Looking at you guys over there, yeah? Twice a week, how many? Pretty good, not bad. All right. Okay, so why is it important to do physical activity? So we know that there is a ton of health benefits to be had. There's immediate health benefits. So if you engage in appropriate physical activity, you'll notice change in your sleep. You'll start to feel a little bit better, less anxiety. Your blood pressure will go down, but there's lots of long-term benefits, including mental health benefits, cardiovascular benefits. There's prevention of chronic disease such as cancer. We can maintain a healthy weight. We can also maintain good bone strength, as well as maintain balance and coordination. Now, there's also financial benefits, if you can believe it, to being physically active. So the WHO, the World Health Organization, estimated the global cost of non-communicable, i.e. non-infectious diseases attributed to physical inactivity. So if you think that the annual cost is $3 billion, put up your hand. 15 billion. Feel like I'm auctioning here. Anybody for 15? 15? 27 billion. Okay, and what are the people online saying? 27 billion. Yes, you guys are so smart. $27 billion is the estimated cost of not moving. That's significant. And of course, as was mentioned by the first speaker, Dr. Inman, in terms of treatment guidelines, we know that physical activity, exercise, physiotherapy is the cornerstone of management for axial spondyloarthritis. It is in all the guidelines that we see that are published. And also there is a ton, an absolute ton of research to really prove the benefits of exercise and physical activity. We know that it reduces pain and stiffness. It improves sleep quality in people with axial spondyloarthritis. It can maintain and improve spinal mobility and strength. It was either Dr. Haroon or Dr. Inman mentioned that people with axial spondyloarthritis are at greater risk of cardiovascular disease. So we know that exercise has a huge benefit in that sense. Mental health and well-being, disease activity is reduced, and we improve function and quality of life. So lots of evidence. I'm not going to go into the details of that, but know that it's good for you. The more we move, the better we're going to feel. So what are these 24-hour movement guidelines? So this was recently published just last year, again, through the Canadian Society of Exercise Physiologists. And what it really talks about is movement behaviors. So it doesn't just focus on activity, but it also focuses on balancing the other movement behaviors that we encounter. So sleep as well as sedentary behavior. And so we know from the slide previous, and everybody knows in the room that we need to be doing at least 150 minutes of moderate aerobic activity per week in order to gain those health benefits. And we should also be engaged in several hours of light physical activities, including standing. And I'm going to get to that standing in a few slides. In terms of sleep, we should be getting about 7 to 9 hours of good quality sleep with consistent waking and going to bed times. So how many in the room think that they're getting, say, let's start conservatively, 7 hours of sleep? How many got 7 hours of sleep last night? Come on, you must have. It was daylight savings. Like, didn't we get that extra hour? You got 7 hours? Did anybody get 8? No? What about online? Are we getting any answers online?
Oh, not in the last 40 years.
Not in the last 40 years. How many people think they're getting 6 hours of sleep? So interestingly, we've done a study on this. In our cohort, people reported that their average hour of sleep is 6 hours a night. They're not meeting the mark. So there's some work to be done there. And in terms of sedentary behavior, we should be limiting it to 3 hours of recreational screen time and no more than 8 hours total in a 24-hour period. How many think you're getting more than 8 hours? Sedentary. Okay, all right. So we got lots of work to do, right? And just on that idea of no more than 3 hours of screen time, I'm going to diverge slightly because this is important. Posture is really important, particularly for people with axial spondyloarthritis. Has anybody heard of text neck? Who has text neck? Everybody in the room has text neck, I bet. Okay, so if we think about the human head, it weighs roughly about 12 pounds. And that is like a bowling ball being held with on a stick. Pencil is essentially what it's like. So when we're in good posture with our head up in a normal position, 0 degrees flexion is how we refer to it in physiotherapy, it's about 12 pounds. Most of us, however, when we look at our phone, our neck is bent at 45 degrees, and that 12-pound head now weighs almost 50 pounds. Can you imagine trying to balance a bowling ball on a pencil that's 50 pounds? So that all that stress is going through those little tiny cervical vertebrae. Ooh, they're little tiny guys. And the muscles in your neck are working really, really hard to stabilize. So just imagine that next time you look at your phone. So what is good posture? And again, if you guys have been to this talk before, you all know this. So good posture is axial extension. And that's where the ear bisects the shoulder bisects the hip, and the hip bisects the ankle. Now, Maria might get mad at me because I'm going to move away from the mic. I'm not allowed to do that, but I have to do it, but I think they can still see. Hello? Okay. So good posture, if you want to do it yourselves at home or wherever, if you just go up against the wall with your heels back and your head back and your shoulders back and just like relax, you don't have to be stiff like a robot. That's going to encourage and optimize that axial extension. All you have to do is just walk away, and we're talking about optimizing, improving. We don't need to necessarily perfect, right? Posture is the foundation of function, and it's the foundation of good exercise. Very often we're like this on our phones as we do and sit and all this sort of stuff. So this starts to feel normal. And so if you do all of a sudden go up, this feels like you're way back here and it feels totally wrong, but it's not wrong. This is right. And so this is what you can do to help encourage that proper axial extension. Okay, and we need to be thinking about posture when we're sitting. So sitting with your buttocks to the back of the chair, feet flat on the floor. Some people like to roll up a soft towel and put it in the small of their back to encourage that good posture in sitting. Standing desks have been a game changer. There's Maria Morales at her standing desk on the right, and we have our radiologist, Dr. David Salonen here, who uses a standing desk at his work. Keeping your back straight when you're lifting heavy items. And the other thing that I want to mention that I don't think that we've adhered to very well this evening is the 30-minute rule. So every 30 minutes, if you're sitting, all you have to do is stand up, set that iPhone that's you're bending over a 50-pound head looking at, set it to go off every half hour. And all you have to do is just stand up and then sit back down. It's just breaking up the consistency of that movement that is really important. If you can walk around, go get a drink of water, even better. Okay, so how do we get moving? So there's different schools of thought. This is my philosophy. First of all, you got to make it fun. You want to do something that you enjoy. You want to set goals. I think goal setting is so critical. So we use what's called the SMART acronym. So you want to make sure that they're specific, measurable, achievable, realistic, and timed goals. So I'm going to give you an example. So say, you're not into exercising much and you want to pick something that you enjoy. So let's take walking. Walking is very simple. Everybody can do it depending on the weather. And say, okay, the goal for me is I'm going to be walking 30 minutes, 3 days a week. Well, actually, it should be 5 days a week if we want to match those targets, right? 5 days a week. And I'm going to do that by the end of the month. And so that's, you've made it specific, you've made it measurable, it's achievable, and it's timed. You say you're going to do it by the end of the month. The other thing I think that it's important is to tell a friend. They can support you, and you're also accountable to that person. You've sort of shared your goals with somebody, and now somebody can kind of say, hey, how's that walking going? Are you meeting your goals? Are you walking 5 days a week? I think one of the biggest challenges is that we need to avoid this boom bust cycle. So this is what happens when, say, 10 years ago, you were jogging and you've decided, okay, I'm going to get active again and I'm going to start jogging. And you go off and you jog 10 kilometers because you're feeling great. Do you think you're going to feel great the next day, the next couple of days? Probably not. You might flare your spondylitis a little bit. You'll probably have some aches and pains just because you're not used to it. And what ends up happening is you then decline in terms of your degree of activity that you engage in. And then you start to feel good again after a little while and you go at it really hard. And so over time, you're getting these cycles of flare, recovery, you do it again, you increase your activity, and over time, you're actually reducing your overall level of activity. So instead, you want to do this very gradually. And so if you think about that walking analogy, where you say, okay, I'm going to be walking 5 days a week, maybe you start off with walking 2 days a week. And instead of half an hour, you're only going to walk 15 minutes. And you say, okay, I'm going to do that for the next week, the next 2 weeks, and I'm going to increase by 15 minutes every week. The key is that you do that no matter how you feel. You stick to the plan. On the days that you're not feeling great, you stick to the plan. On the days that you're feeling really good, you stick to the plan. Because that way you don't overdo and you avoid this boom bust cycle. In terms of seeking guidance, so of course there's physiotherapists out there who can help you, particularly ones who are knowledgeable in terms of axial spondyloarthritis. So the Arthritis Rehabilitation and Education Program through the Arthritis Society is very accessible. Their services are covered through the Ministry of Health. Physiotherapy in the province of Ontario is covered through the Ministry of Health if you're over the age of 65 or under the age of 18, or if you're receiving social benefits, or if you've had an inpatient stay. Otherwise, you have to get physiotherapy covered out of pocket. There's other ways to seek guidance in the community. So the City of Toronto has great programs that are available, and I'm sure that whatever municipality you're living at and across the city across the country has similar municipal programs. The YMCA has great programs, and in Toronto, the Jewish Community Center, as well as Variety Village, they have accessible programs that have a sliding scale. So it's based on your individual income, which allows you to access programs. There are lots of online resources, such as the Canadian Spondyloarthritis Association has great instruction in terms of exercise. The Arthritis Society, NAS, which is the equivalent in the UK. You can find good instruction in terms of exercise and how to progress in terms of physical activity on YouTube. And we at the Toronto Western Hospital have developed an e-learning module called We Got Your Back. And it is under construction for its latest edition. Version 2 will be published soon, and that version is going to be available in both English and French. So just before I finish off here, what I wanted to leave you with is sort of the foundation in terms of what you should be doing, the guidelines around the specific forms of exercise. And so the American College of Sports Medicine, they conducted a really thorough literature review of all the different types of exercise out there and came up with recommendations that you should be doing for each of the exercises in terms of obtaining the health benefits from each form of exercise. So I'm going to go, we've talked about cardiorespiratory fitness, which sort of falls under physical activity, but I'm going to go in a little bit more detail around muscle strengthening and flexibility. So in order to gain the benefits of stretching exercises, they should be done daily. If you look at the recommendations from the American College, they actually say 2 to 3 times a week. I would say in a population where stiffness and restricted mobility is part of the characteristic of axial spondyloarthritis, that doing it daily can often be effective in terms of reducing pain and improving mobility. When you take a stretch, you should take it to the point of discomfort. You shouldn't go past the point of pain, but it should be a little bit discomforting to ensure that you're actually stretching the muscle tissue. It should be a slow and prolonged stretch with no bouncing, and you need to hold it for at least 20 seconds and repeat 2 to 3 times per muscle group. And remember to breathe. Very often we'll hold our breath, but if you exhale and breathe through the stretch, you'll actually improve the quality of the stretch. Strengthening, again, we should be doing it about 2 to 3 times a week. We want to ensure the correct posture when you do it, and we want to ensure correct muscle activation. So what I mean by that is it's good to have somebody who understands exercise, whether it's a physiotherapist or an exercise instructor at a gym, to watch how you're doing your exercises, particularly if you're just starting out. Because technique is so important, because if you're not activating the right muscles, you're going to strengthen muscles that are already strong, and the weak muscles are going to stay weak. So that's really important to make sure that you're using correct muscle activation. You want to progress from remedial to advanced. So it takes about 3 to 4 weeks for muscles to start to change in terms of developing strength, and you get maximal strength in the muscle at 12 weeks. But at that 3 to 4 week mark, it's important that you continue to challenge the muscles and increase the weight that you're using. You should be doing about 10 to 15 repetitions and at least 1 set, if not more. You want to focus on the core muscles, so the abdominals and the back muscles working together to support the spine when you're functioning. And you want to focus on joint stability, particularly around the hips, the shoulders, and the knees. And I just wanted to end with a thought from a person living with axial spondyloarthritis. This is from some research that we conducted here on the perceptions of physical activity in people with axial spondyloarthritis. And one person says that physical activity doesn't have a beginning or an end. It's something where consistency is key, because if you're not consistent with it, your symptoms just end up winning. So I'll just leave it there.
Thank you. Thank you so much for that. We have several questions here, and I'm going to just work backwards through here. Should I consider working with a physical therapist or personal trainer with experience in AS management?
So this is a good question, because sometimes you can't find particularly an exercise trainer who may know about ankylosing spondylitis. You may be the one, you're the expert in your disease, and you may be the one educating the exercise instructor. I think it depends on the extent of your disease. So we know that the most ankylosing spondylitis affects the sacroiliac joint, and that joint doesn't move regardless. So if your disease is solely affecting the sacroiliac joints, you really don't have a lot of restriction that should be imposed on you. You can do pretty much anything that you want to do in terms of physical activity. If, however, your disease affects the spine, depending on the degree of how the spine is affected. So if you have what we call syndesmophyte formation, where you get the bony bridging, that's where you need to be a little bit more cautious in the type of exercise that you engage in. So it's important that you understand how your disease manifests in you and what your radiographic status is, so that you can share that with either your physiotherapist or your exercise trainer, because that's really going to dictate how aggressive you can be with your exercise program.
Thank you for that. Another question here is, how do I balance exercise with rest to avoid overexertion or fatigue?
Yes, and so that's what those 24-hour movement guidelines really are. So it's trying to find that balance between activity and sedentary behavior. And again, I think that boom-bust cycle that we talked about is really important, because you want to make sure that you're gradually introducing new activities, not in a hard, fast way, but in a very gradual way, so that if you are feeling a little bit of aches and pains, or you're not sure about how your body's going to react, you have that opportunity to listen to your body and make the adjustments.
Thank you for that. I'm I'm just searching for a question that I saw earlier, and it was about exercise. Specifically, how does it help with the AS?
So from a physiological perspective, we're not 100% sure. However, there are some studies that suggest that it actually affects the inflammatory response to the body. So there's actually a reduction in terms of inflammatory, like cytokines that are produced, but there needs to be a lot more research in that area that really is quite lacking at the moment. In terms of other areas, so if we look, for example, at disease activity. So disease activity is pain. It's a combination of pain, it's a combination of fatigue, and it's a combination of sleep. So there's lots of studies that support that exercise improves sleep. There's lots of studies that support a reduction in fatigue. And there's lots of studies, particularly in AS and Axial-Spondyloarthritis, in terms of reduction in pain. The mechanisms behind those, again, we don't completely understand. There's a question from...
Hi, Laura.
Oh, hello. There's a live question. This is exciting.
I'm confused. Did you say we should exercise 150 hours per week?
No, 150 minutes. Did I say hours?
Well, that's what
No.
we were trying to figure out.
No, it's 150 minutes.
Gotcha.
And so that's physical activity. So 150 minutes of moderate aerobic physical activity. So basically 30 minutes, 5 days a week, where you're sweating and you're like, but you can still have a conversation. That's moderate aerobic intensity. So it could be anything. It could be walking, it could be biking, it could be vacuuming. And the other thing that I didn't mention in terms of the guidelines is, if that's too much, you can do it in bouts of 10 minutes and still gain the health benefits from it. So it's not a lot, really, right? Like that seems... Yeah, 150 hours seems like way too much, but 150 minutes, that's doable. Yeah.
I would like to thank all of the panelists and the organization and our moderator for a fantastic, really helpful presentation. Yet again, really well done, and thank you very, very much. I have a couple questions. You mentioned you're doing 2.0 of the exercise program. How will we know when it's ready? And until then, is there something posted that we can see? That's one question.
Okay, should I answer that first? Okay, so it's been a long process. And one of the things that we're doing is we're working in collaboration with one of the SPARCC investigators in Vancouver and one of the SPARCC investigators in Montreal, as well as here, to basically revise the e-learning module and to have it translated appropriately in French Canadian. Okay. And then what we want to do is we want to evaluate the impact of this revised e-learning module on something called self-efficacy, which is an individual's confidence in how they can manage their chronic disease. We're looking at its impact on exercise behavior. We're looking at its impact on disease activity, as well as a few other measures. So we are going to be evaluating it before we launch it. But if you're interested in participating in the study, we'll let you know. But that is going to be a pan-Canadian study that we're going to engage in, and we're almost there.
Great. So in the meantime, is there a good resource online, for instance, where people can go and find recommended types and details on the kinds of exercise good for AS patients, and maybe demos, videos, whatever?
So
for all the
version
types?
2 or version 1.0 is still within the public domain. And so it's still up and running. And it's the website was on the slide here. Let me just go back. There we go. So it's wegotyourback.twh.ca. And so there's video exercise instruction, but it's got a lot of good information in terms of how to manage your disease, how your disease may affect, you know, at work, your relationships. It has a chapter on mental health. So it's very comprehensive in terms of its information. One of the reasons we needed to update it is because the medications, this was published in 2016. As we know, there's been a lot of update in terms of medications. And so that's one of the areas of focus for the version 2.0.
Great, thank you. And also for showing where to find that. What do you think about sometimes you read in the media, it's more important to get that, for instance, 30 minutes in little chunks through the day instead of in one fell swoop. What's the reality there?
I mean, you're going to get health benefits no matter what. So it's really up to the individual. And I think it's up to, you know, how you engage in physical activity, what your philosophy on exercise is. Some people are into it, some people not so much. So as long as you're getting those 10 minutes or of, you know, 150 minutes a week, I think that's good, because really the last slide said, any form of exercise is better than no exercise. So as long as you're moving, that is what's critical.
Perfect. I like the owl. Thank you. And I'm also interested in any comments on the biosimilars. I know every province is different now, but any information would be of interest.
So the question for those online is about the biosimilars. So first on safety and effectiveness. So everything to date suggests that the biosimilars are equally as effective and equally as safe as the originator. So for example, Remicade, Enbrel, Humira, all have biosimilars, aka generics. It's been a voluntary transition until recently. So more recently, actually Ontario is the last province to transition. Both BC and Quebec went earlier. But the government supported patients are essentially mandated to move from their originator drug, usually, for example, like Remicade, Enbrel, and Humira, over to the comparable biosimilar. Private insurance is probably coming shortly thereafter. What's driving this, as not surprisingly, if they're equally effective and safe, is cost containment, right? So the cost of biosimilars might be 30 or 40% the cost of the originator. So from the point of view of the provincial formularies, so the Ontario Drug Benefit Plan, these are major savings to the provincial health budget. So it's an example where actually the decision on specific treatment is actually usually historically it's between the doctor and the patient. There's a third party in the room now, of course, the patient, the government or insurance company that's paying for the drug. It's a move that's happened across the world, and all the data, particularly in Scandinavia, where there were large populations of rheumatoid, AS, and PSA patients moving to biosimilars, and then back again to check efficacy. It looks like they really are just as safe and as effective as the originator. But the difference is cost. That's really it.
Question.
We've heard tonight about the fact that there is a connection between mechanical stress, entheses, it's a hard word to say, entheses, inflammation, and AS. So my question for you, it's very personal, but I'll share with the room, is that I've I'm a very, very active person. I have been for many, many years prior to my diagnosis of AS. And in the last couple of years, I've had a lot more problems with tendon damage. Outside of like cutting back my exercise, is there anything else I could do to, I guess, diffuse that, to mitigate?
So when you say tendon damage, do you mean enthesitis or do you mean like mechanical, like?
I've had inflammation in tendons, tearing, partial tears and tears, to the point that I actually had rotator cuff surgery this past summer, and I've had issues with my hip now. So I'm assuming that it's all connected
Right.
to the AS. I don't necessarily want to cut back everything, but I have scaled back to an extent. But I don't really want to, and I don't know if there's any other options for me.
And so I think this is where getting like an exercise expert, whether it's a physio or an exercise instructor, to kind of see what it is you're doing, to kind of evaluate your program and look at your technique, look at what's happening, look at what your needs are. So often, like if you're very active to begin with, I'll give you an example. We may have construction workers, for example, who say, I don't need to exercise because I'm so busy at work, I'm lifting this, I'm bending here, I don't need to exercise. But the argument there is, well, maybe you do, because with your repetitive work that you're doing, you're essentially like an athlete. And so you have to train your body to meet the physical demands that you're asking of it on a daily basis. And so that's when I say, okay, let's see what you're doing. Let's see what we need to adjust. The technique in terms of strengthening is so important, because you may think that you're doing an exercise correctly, but you, again, may not be activating the appropriate muscle groups. And so I don't think it's something where, you're going to need to see a physio, for weeks on end, but maybe just touch base every now and then where the physio or the trainer can look at what you're doing, adjust the program, tweak your technique, and then reassess.
Okay. Funny little side note to that, I am actually a personal trainer. So like I said, since my diagnosis, I have changed a lot of what I do for myself, and even in the last couple of years, things have just gotten worse for me in many ways. So I'm kind of not sure where to go.
And then the other piece of that too, to acknowledge. So we work collaboratively. The rheumatologist and the physiotherapist, we work collaboratively because it's a integrated approach in terms of optimizing your treatment. So it's a combination of the non-pharmacological strategies with the pharmacological, whether it's NSAIDs or TNF inhibitors or whatever. They've looked at this, they've done systematic reviews looking at the combined synergistic effect of exercise and TNF inhibitors or biologics. And the result is better when they're combined than if you're just doing one or the other. So that's the other piece maybe to look at. I don't know.
Okay, thank you.
That's a good question. Just to follow up. So as Dr. Haroon mentioned, biomechanical loading in some of the experimental models, it's actually a bad thing. But Laura's telling us loading joints and active is a good thing. So where's the balance there? So I think what we can say, since you mentioned rotator enthesitis, we do know that AS patients are predisposed to inflammation at the site of tendon insertion. So that's kind of a background. So there may be specific exercises. I mean, I think you've always recommended swimming, where you achieve your cardiovascular workout without biomechanical loading. What would you say? Stationary bike, elliptical, swimming?
Yeah, and again, I think it goes back to what your personal goals are, but also what is the radiographic status of your disease. So swimming is good, but not everybody likes to swim. And how does swimming translate into our data? Like we're land dwellers, we're not, you know what I mean? So swimming is good because it combines different types of exercise, such as cardiovascular fitness, flexibility, core strengthening. But you also have to think about how that translates into our day-to-day function. So on that recommendation by the American College of Sports Medicine, they include a type of exercise called neuromuscular strengthening. So what that means is strengthening the muscles in a very functional way. So I'm going to need this thing again here. Is this on? Yes. So for example, if we wanted to strengthen our quadriceps muscles, which are the big muscles on our thighs, we could go to a gym and we could get on a machine, or we could put a weight on our ankle and we could extend our leg, and that would sufficiently strengthen this muscle. But a more functional way to strengthen that muscle is if you were to do squats. Okay, because the squats then translate into getting in and out of a chair, getting up and down stairs, walking, whatever. So it's a much more functional way of strengthening the muscles. So in making sure that you include that form of exercise is also important, because that's going to translate into improving your day-to-day function.
I'm going to ask one other question, and while you answer, we're going to transition into another slide deck here. And the question was, if I remember it correctly, I work full time in an office at a computer. How do I manage my screen time without my employer or my colleagues thinking that I'm not working as hard?
Okay, screen time or sitting? Screen time. Oh, okay. Well, I'm going to talk about the sitting first, because when you're working in an office, again, using that 30-minute rule is going to be really important. Making sure that you're not sustained, like many of us have been this evening, for more than 30 minutes at a time. Now, as far as the screen time goes, I think that's an interesting question. Can you read the question again?
I think it's.
Oh, I see what you're saying. The posture of it. Okay, now I understand. So yes, so that's going to be very important. So the setup, your ergonomic setup of your workstation is critical. And there's lots online that talk about what is the ideal setup. So one thing that we have to make sure is that the monitor is directly in front of our head. That working on a laptop, I'm going to show Dr. Haroon as an example here. Sorry. So text neck. So if you're working on a laptop, you're naturally looking down. And again, that puts a lot of stress and strain on the small muscles and ligaments in the cervical spine. If you're working on a monitor, then your head is going to be in proper position, but you have to make sure that the monitor is in front of you. It's not off to the side, because then you're turning your head the whole day, right? And standing desks really are game changers in terms of health outcomes. So if you have access to an ergonomic, whatever fund at your work or place of employment, or you have access to an ergonomic assessment, I would look into that, because standing desks have really changed the game in terms of how we feel at work, our productivity, our health outcomes. They're really important if you can access them. That's right.
Oh, so people could hear me online. Additional benefit, your brain gets into a better functional waking state when you're looking forward or up as well. So standing desks, having your monitors at least level with your eyes are all beneficial that way.
Yes, absolutely. Okay.
Thank you so much. We're just getting this last slide deck ready to go. But I'm going to keep, oh, yeah, we're just about there. Yes, it's this. Oh, there we go. Okay, so I am going to try to do this in less than 10 minutes so that we can have some more questions. I just wanted to share a little bit about the CSA, and wanted to start off with a little bit of history. So the CSA was founded in 2006, and it was founded by SPARCC and by patients collaboratively. And then in 2021, we were accepted to be, our registration was accepted. And so we are a registered charity, national charity. And the officers, the directors
of the organization, they experience SPA firsthand, either themselves or through someone that they are very close to. So they influence it. And there are over 8,000 members registered nationally and highly engaged group. And we're so very grateful for all of you who are participating as members and helping us to shape the future of the organization. This slide is a little bit about what we already know, so I'm not going to spend too much time on this. But the one thing I did want to say is more people are affected by SPA than MS and ALS combined. And so we're really working hard at the CSA to really shine a brighter spotlight on this disease that is so relentless. I also wanted to mention that one thing that I find very alarming is that within 5 years, many patients become resistant to their treatments. And that's why we're constantly working hard to advocate for new treatments to be available. I also wanted to share this slide and just to take a moment to thank the supporters of the CSA. With over, 500,000 individuals in Canada battling this disease, we can't do this work without you. And we also offer this slide to everyone in full transparency, but really wanted to say thank you. We are very grateful for your engagement and your support. So as we look at some of our work at the CSA, I just wanted to highlight a few pieces. One is our educational webinars. They are available on the website. If you haven't seen them, go check them out. Most of which are now available in both French and English. So we work very hard for that on that. If there are topics that you want to learn about or want more information on, please let us know. We are constantly evolving this piece of our portfolio, and your input is absolutely vital. We want these to be very relevant for you. We also have an extensive resource library on our website, and our as we mentioned at the AGM, this is a new website that we launched with our new brand, and I hope you agree, it's pretty awesome. And but there are lots of resources on there, and we hope that you use them. Many do, and we are constantly creating new tools for you. One tool in particular that I did want to highlight, and if you haven't seen this yet, I encourage you to go to the website to look at it. It is the treatment risk tool, and it's a tool to help you to better understand and to empower yourself with your own treatment. It's an opportunity to provide a list. It generates a PDF document of questions that you can take to your healthcare provider about your concerns. And it informs you about the actual risk of treatment versus no treatment. So it's a really great tool. It's one of our newest resources, and we're receiving a lot of great feedback on that. I also wanted to touch on our support programs. I mentioned validation. A lot of individuals just feel that this invisible, quite often invisible disease is, a lot of people say, oh, you look fine. You're okay. You'll just get through it. It's a phase. And so these support programs are really to help you to validate and to show that you are not alone. The support programs are available virtually, and in some areas we are launching them back in person again, but it's just a great opportunity to reach out and to connect with others and learn from one another. Second last slide here, I want to talk about exercise. So just riffing off of what we just heard here. Yoga, stretching, breathing, relaxation. We know that that these types of exercises and practices can really help people living with SPA. And if you haven't registered for the yoga program, it is free. And we're actually looking at adding some more types of exercise programs and would love some feedback. I know that there's some expertise in this room by patients, and would really like to hear what would be beneficial and meaningful for you. but we're looking to add in Tai Chi and other types of programs as well. So, you know, as a registered charity, we are all in this together, and we can't do this work without you. And, you know, thank you for being members. Thank you for being engaged. There are always opportunities to volunteer. There's always opportunities for fundraisers. And like I said, we want to hear from you. So please reach out to us. Let us know what you need, what you want, where you think that there are gaps, and we want to support you. You know, we always say that there's a group of SPA warriors ready, willing, and able to support you and to have your back. So that wraps up my slide deck. I wanted to go back into the questions, if that's all right with everyone. Okay, so we're going to pass around some, I know the cameras are up here, so perhaps that maybe as questions are being asked, you know, grab a microphone, come over here, and I know that the camera will span out. Okay. I'm just going to sit down here so I can read these questions as we go. And if there are other questions here with those that are participating live, please put your hand up, and Maria will ensure that we'll do our best to make it through to you. Okay, so these are in no particular order. The first question I have is, why can some people respond to biologics within a few weeks versus others who take 2 to 4 months?
Everybody's different. It depends on where you are in the pathogenic process, right? And how responsive the immune system is. Yeah, the short answer and straight answer is everybody's different, and everybody's immune system is different.
Thank you.
I mean, we have some clues, but most of it's Dr. Haroon said, but for example, biologic effect in female AS patients is not quite as predictable as in male AS patients. We don't really understand the biology of that, but that seems to be, is that a function of the outcome measures we use or our diagnostic confidence in the patient population? But it raises some important questions. But
Thank you for clarifying that. And it is so unique, really. And that's what we see quite often and hear quite often as well. And so moving into the next question, why do many AS patients experience fatigue, and what is the connection between AS and tiredness? Is there a connection between disease activity and fatigue and underlying inflammation? That's a packed question.
I could start. Inflammation and as I said before, nobody likes stress. Similarly, nobody likes inflammation. So the cells really have to work a lot in your body when there is a lot of inflammation. And just as an example, when there is a lot of inflammation in a site, the relative oxygen levels, if you measure the oxygen levels, it drops down significantly. That's because the cells are using up a lot of oxygen, working overtime. And what happens when you work overtime? You get fatigued. That's what's happening at a cellular level.
I mean, part of that might be a protective response on the immune system. Like if you get the flu or maybe COVID or a bad infection, like you're wiped out, right? And as Dr. Haroon said, maybe your body is using a lot of that metabolic energy. Maybe it's a protective mechanism where we just need more rest. And so back to some of the frustrations of the diseases having to perform in the workplace or your sport when you're fatigued is a tough problem. Back to our inner studies with our neuroscience colleagues, if they who've been interested in seeing what happens after you've on the neurological level, start a biologic, the pain scores improve much more quickly than the fatigue scores. So fatigue seems to be a kind of a more resistant component sometimes than the pain, but I don't think we really understand the biology.
And just from an exercise perspective, so that paradoxically, we know that if you suffer from low to moderate levels of fatigue and you engage in cardiovascular exercise, you can actually improve those fatigue scores. But if you suffer from high levels of fatigue, then it's harder to manage it through exercise.
That's really interesting. I'm sure we could go into that for a while here. So this is an interesting question I found as well. And it's about, there's so much evidence out there that people totally cure their arthritis conditions with a plant-based diet. In your day-to-day practice, out of 100 patients, how many do you see that come in and say that that they have a plant-based diet and that it's improved their conditions?
I'll pass it over to News in a sec, but 3.5 patients out of 100. No, just kidding. It's a very common question we get in the clinic. If you look at well-controlled studies that use either over-the-counter, what we call nutraceuticals, or plant-based diet modifications, so-called anti-inflammatory diets, there's a huge range. And a lot of it, the claims aren't really that substantiated by solid evidence. A related question is, why is that? Why are we not doing more randomized control studies with diet interventions? It's a very important question. We haven't got a good answer. In many ways, we turn to the national funding agencies, Canadian Institute for Health Research, for example. One of the issues there is how to really control these studies appropriately. This comes up, for example, in studies of cannabis control of pain, which is a very common question these days. Because there's not really batch-to-batch control of the quality of the product, it makes clinical research sometimes difficult. But diet, Mitch? Any other?
Yeah, we do have infrequently patients who come in, and what I've noticed is that those who feel they improve with dietary control, giving up starch and all, are on extreme diets. Like giving up one piece of bread once a week will not work. In those patients, they go into extremes of making their own salad dressings, looking at the composition of medications they take to make sure there is no starch or carbohydrate content. So in those individuals, they come back and say, yes, I feel better when I do that. But if I cheat one day, you get a flare. So is it a long-term solution? I'm not very sure. Is it related to is there a biological basis? Perhaps there is, because it may be related to our microbiome. It may be related to the immune responses in the gut. But if just as an example, I've lived 10 years, let's say I live 10 years in Toronto, and for 2 days I go to another country, my microbiome changes within 48 hours. So it's so transient. And how effective is this kind of practice going to be? And I feel that it is only it's incremental. I don't think that'll be the only solution. It'll be additive and beneficial. It'll be complementary to other measures that we have.
I think the other point is just I would say more to the question about what we hear in the clinic is cutting back on processed sugars, cutting back on starch. And many of our patients anecdotally feel better. They also have lost a substantial amount of weight. Right. So we really don't know whether it's an intervention or withdrawal of some kind of toxin, change in the microbiome. We certainly know that fat tissue is pro-inflammatory, adipocytes that live in our fat tissues. So when weight reduction, besides the mechanical aspect of lowering stress on our back, there's a beneficial effect on weight reduction.
That's what I was going to say. But also too, though, you also see this cascade effect where people start to feel better because they've lost weight or whatever the driver is in terms of diet. And then they start engaging in more exercise. And so one thing leads to the other, and their whole lifestyle and behavior change, is affecting their disease outcome.
Thank you. Next question I have is, what is the role of autoinflammatory genes in AS? To what extent is AS mediated by the innate immune system as opposed to the adaptive immune system?
Must be an immunologist asking the question. So if we go just by the one figure I showed where how HLA-B27 leads to disease. So if you're presenting the antigen, the immune system adapts and you get an immune response. So that's where the peptide and the antigen and all comes in. So if it's an innate immune response where you're or an autoinflammatory response where there is no adaptive response from the system. And that'll be the second example where B27 accumulates in the cells. You undergo a lot of stress, and the stress leads to inflammation. So it's more of an auto-inflammatory process. Which one is more significant over the other, I'm not sure. And if you go by the example I showed you from the mouse model, sorry, the rat model, where you get rid of the antigen presentation issue, the arthritis improves, but that leads to an increase in the cell stress, that leads to a worsening of gut inflammation. So perhaps all immune responses are significant. It depends on which tissue and where in the immunological process we are at that moment.
Okay, thank you. I have a couple of weather-related questions here. The first is, does weather affect spondyloarthritis? Do flare-ups occur in cold weather, such as it occurs in Quebec during the winter months? So does living in a warmer climate relieve some of the symptoms?
I can start, and this is very anecdotal, and a lot of patients feel there is a relationship to weather, there is a relationship to the temperature. Some people feel, they can really work as a weatherman. They'll tell you a few hours ahead whether rain is coming or not. So it's definitely something that is experienced by patients. Now, is there proof? People have tried to study this. People have tried to study this and in inflammatory diseases. So comparing people with the same disease living in a hilly area with a high altitude compared to the lower levels where the weather is different, the altitude is different. But when you look at it statistically, there is no difference in the number of flares and the severity of pain or anything when you do that statistically. But for an individual, and very classic example is if you have an injury, some people prefer cold, some people prefer hot compress. So it all depends on how your body responds. So I don't think the other correlation with environmental changes is those living in higher altitudes tend to have slightly higher risk of immune diseases. That has been attributed to difference in the exposure to sunlight, difference in vitamin D processing in the body and vitamin D levels, because vitamin D is an important vitamin that modulates the immune system. So that could be an indirect effect that is happening. Yeah.
And I think that there are a lot of secondary co-factors that go along with this. So not infrequently, for example, we might have a patient who's shoveling the snow the first week in January. They fly down to Phoenix or Fort Lauderdale. And the next day they're swimming and walking on the beach. And they say, I feel great down here. Well, there are a lot of things going on there, right? Besides not shoveling snow and having freezing weather, they're getting into a meaningful exercise routine, but they say, maybe I should just move to Phoenix full time. So obviously it's a tricky question. I think when in rheumatoid arthritis, where the studies have been done, and we actually blindly assess temperature and barometric pressure change versus symptoms, it's not that great. I mean, we have some patients that are super weather predictors, but the correlation is not that great.
We actually looked at this in terms of qualitative study, looked at the barriers and facilitators to engagement in physical activity in people with axSpA. And that came up as a theme, a very clear theme, the environmental impact in terms of ability to engage. So, the environment itself, so the walkability of a city, for example, but weather, inclement weather, snow that we have to deal with in Toronto. So it like you said, it can be a very indirect relationship.
Just as one aside, the population in North America that's got the highest B27 rate are actually northern First Nations, the Haida and the Bella Coola, and farther in northern BC. So that's not to say that cold weather is bad, but it's just an example. Once again, there's always a genetic environmental interaction, not one or the other, but both.
That's great. And I think we have time for just two more questions. Those questions that we did not have an opportunity to respond to, we will address those after this event. And this question is specifically for Dr. Haroon. Before taking biologics, as Dr. Haroon mentioned, there are many screening tests, tuberculosis being one. What if someone had skin tuberculosis many years ago and is cured? Can taking biologics resurface? And I'm just going to leave it at that. Can it resurface?
Yeah, so there is always a risk. The risk is not zero, but we minimize the risk, and by doing these investigations ahead of time, that is exactly what we're doing. We're minimizing the risk. Nobody can say there is zero risk. Now, what are we doing specifically with the TB skin test? We are looking for the body's response to the antigen, like what is present in the TB bug. So essentially, you're testing whether your immune system has been exposed to this agent sometime in the past. So when you get a reaction in the skin, it means that you have been exposed to it. So maybe there is a little part of the TB bug that you were exposed to before hiding somewhere in the system. So the second level of the test you do next would be to look for active immune response. And there is a specific blood test which you can do. So that we usually do that as a second step. The third thing that we do is we do a chest X-ray. On the chest X-ray, if there is anything active or something that looks suspicious, we can pick it up in a chest X-ray. If all of these are negative and it's only a TB skin test that is positive, generally you get treated. You don't get treated as active tuberculosis. You get treated to suppress, if at all, there is any active bug somewhere. It's a lower level of treatment. Now, these 4 or 5 steps that we mentioned, the level risk of reactivation of tuberculosis drops down significantly. And I have not seen any I don't know, Rob, if you have seen any reactivation of tuberculosis. I have not seen any reactivation of tuberculosis in Canada with biologics. Yeah.
That's great. Thank you so much. Oh, we have a live question.
I wondered if there's any comments on COVID and the AS population and immunosuppression. Also, if you could tell us about what your current research is. And Laura, if you were standing up at a sedentary office job every 30 minutes, what would you actually do? Could you demo what you would do besides standing and sitting?
I do this at home because I'm not always in clinic. So I am in front of a computer most of the day and I am up and down all the time. And it's just like, if I'm at a meeting, I'll just stand and like be in the Zoom meeting. This is what I do. I stand up, I sit down. I can't sit still. Maybe that's partly my own problem. I go try and find the cat in the house, see where's the cat, like it just, whatever it is, just to get me moving. Go get a glass of water. And the more water you drink, the more you have to go to the washroom. So you're running around the house. Like I'm up all the time. I was up all the time here. I don't know if anybody noticed that.
So buying a dog is actually a good thing to do. Because our dogs actually encourage a daily walk. I would say, Kathy, generally on the positive side, the biologics we use, the anti-TNFs, the IL-17 blockers, in terms of immune response to COVID vaccination or even recovery from a COVID infection, happily have not proved to be really worrisome. There are some biologics. Rituximab really impairs immune response to vaccinations. High-dose prednisone changes immune response to the infection, but happily, I think the biologics in our space have not really raised a lot of really worrisome signs in COVID. You agree, Nish?
Okay. Yeah. And in fact, those who have been on biologics tend to have less severe outcomes of COVID because the more severe outcomes of COVID are related to excess inflammation. So you're already suppressing your inflammation. And so the less severe outcomes when you're already on a biologic. Yeah.
Okay, thank you. I'm just gonna wrap up here. I know that there are some questions about physiatrists. I know that there are some questions about CBD and cannabis. So we will address all of these questions afterwards. But I just wanted to express our thanks and our gratitude for your taking the time to share some of your precious hours with us and really appreciate the level of engagement. This was really interactive, and following this event, we will be sending to you a questionnaire. We want your feedback. We want to know what you liked. We want to know what you didn't like. We want to know what you want more of, less of. So please, if you could just spare a few minutes to address that email that we will be sharing, we would really appreciate it. We are here to serve you. We are here to support you. And this disease can carry with it a heavy burden. And we want to, be there to show you that you are not alone. I wanted to thank our amazing panelists here today for graciously offering your time and your expertise and your wonderful energy. And I wish everyone a good rest of your day. Thank you so much.